Hello, everybody. We have an exciting symposium on Noncystic Fibrosis Bronchiectasis. I'm here with four wonderful clinicians who are interested in bronchiectasis. And Dr. Huan Gu is an assistant professor in the Department of Chemistry and Chemical and Biomedical Engineering with the University of New Haven. Colin Svensson is an associate professor of medicine and director of the Bronchiectasis and NTM Lung Disease Clinic at Emory. Dr. Ashley Losier is an assistant professor of medicine and leads Yale's Bronchiectasis and NTM program. And Dr. Sunjay Devarajan is an assistant professor in medicine at Baylor and works intensely in non-CF bronchiectasis and also cystic fibrosis bronchiectasis. Welcome, everyone. This is going to be a lively discussion. Dr. Huan Gu will first go ahead discussing mucus structure and function, followed by Colin Svensson, who will speak to the microbiome in non-CF bronchiectasis. And then Ashley Losier will close with a presentation on airway clearance, and we will intersperse this with moments of real-time discussion on lively aspects of the management of bronchiectasis.
Thank you, Onel, for the nice introduction. And I'm probably the only doctor here who doesn't work in clinic. So today, hopefully I can share some knowledge about the mucus layer from the chemistry and the materials perspective. Hopefully this can build a foundation for your understanding of other things about the mucus layer, how it's affecting human health and diseases. So I would like to see the mucus layer as the fishing net inside of the ocean or water. So it's composed of 99% of mucins and water, and then the rest of 1% is composed of electrolytes, lipids, proteins, and etc. The ratio between the mucin and water basically controls the chemistry and materials property of the mucus layer. So there are 21 types of different mucins, but not all of them can be used to make the fishing net. Only 5 types of the gel-forming mucin can be used to actually manufacture the fishing net. And then these are the 5 different types of the gel-forming mucin. And the material property of the mucus layer basically are controlled by the viscosity of the water and also the elasticity of the gel-forming mucin. This basically controls what type of particles can pass through and what type of particles can be filtered out by the mucus layer. So the mucus layer can be functioned as a front line of our defense system. So there are different types of mucus layer coating different organs in our body, and then their material properties and chemistry varied a lot. So some mucus layer move, but one overall characteristic of the mucus layer is that it's always moving. So some mucus layer move faster, for example, the mucus layer in the airway, and some of the mucus layer actually move slower, for example, the mucus layer in the GI tract. And then, so because of the material property in combination with the movement of the mucus layer, it basically functioning as the giant filter which controls what type of particles can pass through and what type of particles cannot pass through. And then its material property basically controls how it is functioning and its role in human health and diseases. So currently, there are not too many type of technologies that can be used to quantitatively evaluate the material property of mucus layer in vivo. But in vitro or ex vivo, there are different technologies that have been developed to quantitatively evaluate the material property of the mucus layer. For example, multiple particle tracking, MPT over here, has been used both in vitro and in vivo. And in vitro, we can also use some other analytical method, for example, AFM, to measure the microbiology of the mucus layer. So with the data actually obtained right now with the data mining and also artificial intelligence, we can develop models to mimic or predict how the mucus layer actually is moving and how the material properties controls its function. So the mucus layer actually varies between healthy people and patients. For example, here in these slides basically shows that the difference between the mucus layer, specifically the gel forming mucin, I mentioned before, it controls the net, the fission net of the property of the fission net, which are muc5AC and muc5B. And this gel over here in the middle, the small figure B, tells you that the difference between healthy people and the non-cystic fibrosis bronchiectasis patients. So you can see that the muc-AC has expressed a lot inside of the patients, but not in the healthy people. So these basically is a huge difference that has been observed between the healthy people and patients. So we're still studying like how it actually affects or contributes to the disease of the patients, but definitely there is a huge difference between healthy people and patients. And then, as I mentioned before, the mucus layer controls what passes through, and also it controls what lives inside as well. For example, the microbiome. So on this slide, what it shows is that basically people have did the sequencing of the 16S ribosome RNA, and then what it find out is that please look at this figure B, and then the distribution pattern. So between three type of people, so the column with N actually are healthy people or controls, and then compare with the patients with the asthma or some other disease, chronic like pulmonary disease. So you can see that the microbiome inside of the mucus layer are closely related with each other. It's very diverse. But you can see that between the patients and healthy people in different positions, for example, in the nose or oral pharynx or left upper lobe, you can see that there is a shift in terms of the composition of the microbiome compare the patients versus the healthy people. So, but then their compositions are diverse and also very similar to each other, and it affects the immunal responses of the human body against those microbiomes. So this is my last slide. So basically the mucus layer, the healthy mucus layer, you can see from figure A is that the healthy mucus layer supports the diversity of the microbiome, the species, so they can balance each other. But the unhealthy mucus layer actually will promote the significant growth of the pathogens or the bad ones. And then the mucus layer actually accomplish those controls through different ways. For example, you can control the three-dimensional organization of the microbiome, and it also controls how they're signaling between each other and their metabolic activities because of their chemical properties and also material properties. That's it for me.
Thanks, Dr. Gu. That was great. I think you're the smart one here. You're the basic scientist, and I think you know a lot about the mucus properties that can really allow clinicians to have a much greater breadth in how they sort of prescribe treatments and in sort of an evidence-based way, at least in an in vitro way. And one of the things that in the non-CF bronchiectasis world that we use as part of our airway clearance strategies that Dr. Lister is going to talk about soon is hypertonic saline. And I was sort of wondering as you were talking, what is the role of high salt sort of inhaled solutions on sort of the viscoelastic properties of the airways, and how do medicines like hypertonic saline help with mucociliary clearance in patients with non-CF bronchiectasis?
So definitely it helps thinning the mucus layer. So one thing that is commonly reported is that the salt level inside of the unhealthy or patient's mucus layer is higher. So which makes the mucus layer of the patients more viscous. And then so the saline definitely can thinning the mucus layer, help thinning the mucus layer. So it can also helps the drug discovery, drug delivery, because it basically helps the mass transport inside of a thinner mucus layer. Another thing is that it can also helps the distribution or the organization three-dimensional structure of the microbiome inside as well. But however, I think there are probably a couple of challenges that we have to think about when we actually think that it's going to be useful, is like how it is going to be delivered, because we do have our airway is not straight. So if we're inhaling it, so how much particles can actually be delivered into the lung, and especially the different like microstructure inside of the lung, how far can you actually deliver it? It's a big challenge. Maybe you can only deliver it to the major airway, but not to the micro part where most of the mucus layer is actually having trouble. So I know that some people also try to stimulate the epithelial cells to produce some of the the solutions which can help thinning the mucus layer from the inside instead of like inhaling the saline. So but overall, I think the basic strategy people have been thinking about is trying to make the mucus layer thinner inside of the patient's lung, because it would definitely help the, like as I mentioned before, like help the drug delivery, and for example, antibiotics that you will prescribe, it can like reach their targets better, and also it will make it faster to be removed because it's getting thinner, and also it will definitely change the material property of the mucus layer and make it less viscous.
Juan, thank you for that. If I could jump in here, one of the things in my readings about this is that the models for the airway surface liquid, they're not very clear, because a lot of the times you're looking at ex vivo constructions of the mucus layer, and their artifacts, pores that are created just because of the process of creating those samples for testing. So it seems that there a lot more work is left to be done in creating the ideal model for studying a non-CF bronchiectasis.
Yes, it's definitely a challenge. Another challenge is that right now, as I mentioned before, there are technologies that can be used to measure the microbiology of the mucus layer in vitro, basically outside of human body. But actually, more importantly, is that we want to develop technology that can actually quantitatively measure or determine the microbiology of the mucus layer inside of human body, because the mucus layer not only made of mucins and water, they also have a lot of immunoresponsive cells in it, and also other things in it, like a microbiome, like the bacteria cells. So its material property is not only controlled by mucins and water, it's also controlled by all these different things, cells, and then the immunoresponsive cells like macrophage, and also the bacterial cells live inside. So definitely in vivo will share more insights about the help the development of the better modeling, a model of the mucus layer than in vitro measurement.
Well, we're going to leave it there. Colin, it is now your turn to tell us about the microbiome of patients with non-CF bronchiectasis. Thank you so much, Juan, and we'll come back to you later.
Very good. Well, hello, everyone. My name is Colin Swenson. As O'Neill mentioned, I am an associate professor at Emory. I'm going to wade into a very difficult and complicated subject right now, which is the non-CF bronchiectasis microbiome. which is, as I mentioned, very complicated. And it's also something that is rapidly changing as our sequencing becomes more precise. And as our understanding of microbe, and microbe-host interactions develops. So first off, a list of my disclosures. And I wanted to start this off with just a very, very simple question, which is, what is the microbiome? I know that's a very hot term right now in any number of different areas, not only in the area of bronchiectasis, but certainly in other organ systems. So the microbiome is the combined genetic material of all microorganisms in a given environment, and that includes viruses, it includes fungi, it includes bacteria, and so forth. Each of these are referred to individually as the bacteriome, mycobiome, and virome. And it should be said that there are a vast array of microorganisms in animals of all stripes, including humans. And there, as I mentioned, there are very complicated interactions that occur between the host and the microorganism and other microorganisms in the environment. And all of these have an effect on health and disease of the host. We, at one point, used to think that the lungs were sterile up until not too long ago, relatively speaking. Pulmonologists thought of the lungs, the airways, as sterile, and we now know that's simply not true. So normal genera in the lungs include Prevotella, Strep species, Veillonella, Neisseria. And just to give you an idea of the amount of heavy lifting that the airways do in any given day, they take in essentially 14,000 liters of air, 2 liters of saliva, mostly in the form of microaspiration. Yes, we all do it, and over 100,000 bacteria per day. So certainly not a sterile environment. As I mentioned, the microbiome is different in the normal lung and in diseases of the lung. So in the normal lung, the microbiome is something that is quite transient. It is affected by microbe ingress into the environment as well as clearance, and we'll talk a little bit about that as this presentation goes on. So in terms of ingress, there's inhalation, there's microaspiration, there's also the rate of mucociliary clearance, as Juan just discussed in her excellent talk, and also immune clearance of the host organism. There are local and regional factors that favor growth or favor elimination. Now, in lung disease, what happens is one gets structural changes in the environment. In our case, of course, bronchiectasis leading to architectural distortion of the airways. This results in impaired mucociliary clearance and, of course, impairs our innate ability to defend ourselves from these microorganisms. So in bronchiectasis specifically, you get an increase in microbe adherence, you get ineffective clearance, and the end result of that is that one ends up with an increase in microbial load. I like this illustration by Richardson that was published in the European Respiratory Review in 2019 that essentially gives a schematic of that entire sequence of events, starting with microbial immigration, the patient factors that result in increased immigration of bacteria into the airways. This includes upper airways diseases as well, which we have not really touched on, impaired swallowing, which we see a lot in our elderly patients, and certainly gastroesophageal reflux disease. And there's certainly an environmental component, as we know from NTM studies, and certainly exposure to healthcare environments can result in growth of multi-drug resistant organism. And lastly, patient-to-patient transmission as well. Then there are the microbial factors that result in increased virulence, including epithelial adherence. And then we have our decreased elimination. And again, you have patient factors, you have environmental factors, and microbial factors at play. And all of it results in this very delicate homeostasis between microbial immigration and perseverance and elimination. So when discussing the microbiome, there are a couple of terms that we need to become familiar with and comfortable with. One of them, of course, is the simple difference between culture-based isolation of an organism, which is growth of an organism on culture medium. This is the very traditional way that we have isolated pathogens in the past, and next-generation sequencing, including 16S ribosomal RNA sequencing. So this is the 16S ribosomal RNA is very common in prokaryotic ribosomes, and it's preserved over time. It is more sensitive in culture, and I'll touch on that in a future slide. Then there's richness. Now, this is how many species are in a given sample. There's evenness, which is the abundance of each of those species in the sample. There's alpha diversity. We will talk about that as well. Alpha diversity is diversity within a single sample in terms of richness and evenness. And then there's beta diversity. And these are how different samples differ from one another. And this is a simple schematic from that same paper by Richardson showing in the healthy microbiota up top, you have strong alpha diversity. It is rich and it's even. You can see a lot of different colors there, and they're in relative abundance to one another. And then as you go down to the diseased schematics, so you have in the bottom left, you have a sample that is rich, but uneven. So in this case, the green corresponds with Pseudomonas aeruginosa. And then over on the right, you have really sort of loss of that richness with only 3 or 4 species present, as you can see from those colors. So in the healthy lungs, as I mentioned, the composition is really transient, and it depends on the ingress and egress mechanisms that we talked about earlier. At the genus level, when we do next-generation sequencing, the most common genera that we've isolated are strep species, Prevotella and Veillonella, but Neisseria is also commonly encountered. So compare that to the bronchiectasis microbiome. And I know that this slide is a little bit complicated, but really the microbiome in bronchiectasis is dominated by proteobacteria such as Pseudomonas and Haemophilus, which are both linked, by the way, to increased severity of disease, exacerbation frequency, as we all know, and the Firmicutes such as strep. The pie chart over on the left that you see here is data from the European cohort. That is culture-based data. And what it shows is an overwhelming preponderance of Pseudomonas and Haemophilus species. At the right is a different paper and a different schematic showing next-generation sequencing. And really what it shows is overall overwhelming agreement with the culture-based data in the pie chart at the left. It really shows Haemophilus, it shows Pseudomonas predominate, but also you can see strep species as well that are quite abundant. And I like to include this slide because it really just shows the relative sensitivity of culture relative to next generation sequencing, in this case, the 16S ribosomal RNA gene sequencing. And in this case, you can see that for Pseudomonas, there's a 52% sensitivity for culture as opposed to sequencing. And it really, a lot of it is dependent on which sort of genera we're trying to isolate. And again, I know that this slide is a little bit complicated, but this is data from Wu et al. That was published in 2019. It showed 29 patients with non-CF bronchiectasis. You can see all of these charts here are labeled 1 through 29, and you can see in the x-axis there is the number of years from the baseline sputum sample. And you can see that in most of these patients, the species composition is really relatively stable over time, even when treated with antibiotics. You can see there is a difference in the alpha diversity, most visible in the patients with higher levels of Pseudomonas, which is that dark green color. From that same study, they did a sub-analysis of rapid decliners in terms of FEV1, so spirometry. And what it showed was that among those who had a rapid FEV1 decline, there was really low richness and diversity. Haemophilus and Pseudomonas species were rarely isolated in culture together, which really suggested an antagonism. And what they found was that Pseudomonas and Haemophilus were associated with decreased diversity, as well as worse clinical outcomes, including FEV1. So in short, the bronchiectasis microbiome, it appears, is highly individualized, and it is remarkably stable over time, even during exacerbation. Proteobacteria such as Pseudomonas and Haemophilus tend to predominate, as well as Streptococcus species. There are no consistent changes during exacerbation in either alpha or beta diversity, and really lower microbial diversity equals a more severe phenotype. And we see an increase in severity, clinical severity, in terms of exacerbations, decline in FEV1 in patients who are chronically colonized with Pseudomonas, particularly mucoid Pseudomonas, Enterobacteriaceae, and Stenotrophomonas species. And so with that, I will conclude my portion of the talk.
Colin, that was fantastic. There is so much that I want to ask you, but I know we're short on time. But, I wanted to, this is really exciting. And, it kind of feels like this is the right direction to go with this disease, given the complexity of the microbiome and how different it is from the healthy microbiome. I'm a pulmonologist like you who takes care of a lot of these patients. But, if you're a community pulmonologist, you've got a patient with moderate to severe bronchiectasis, chronic cough, sputum production. I mean, what's your approach? What do you think people should be doing in terms of surveillance sputum cultures and the type of testing they do? And in that sense, if the patient's, easily producing sputum, do you need to be doing bronchoscopies for collection, like more invasive collection, deep collections on these patients with non-CF bronchiectasis?
Well, I would say that you just asked a bunch of questions wrapped into one or two questions. So we could probably diverge into long talks about each one of those. But
controversial questions at that.
Yeah, well, I would say that not everyone really has access to next generation sequencing, particularly in clinic. Some of us do, and it's being more rapidly and sort of readily adopted in the clinical environment, particularly on the inpatient side. But culture is really sort of the mainstay for most clinicians, and so it is my practice in my program, both with my NTM patients as well as those colonized with other pathogens, to try to get sputum samples regularly. Now, what regularly means, I think, is a little bit relative. But what I always tell my patients is, if you have any cardinal signs of exacerbation, increase in cough, increased sputum, change in the sputum, hemoptysis, fatigue, fever, whatever index you want to use, go ahead and turn in a sputum sample. And typically what I do is I order both bacterial, really all three, bacterial, fungal, as well as AFB cultures, to try to get a handle on what might be triggering that exacerbation. But what the data shows from this next generation sequencing is that it's not so cut and dried. So there are oftentimes other players, sort of corroborative microbiome, these other bacteria there, that can be, that does have a role in exacerbation that perhaps we're not capturing. So while and that's what we're seeing with the data that was published in 2019 by Wu, is that even during exacerbation, the relative constituents of individual microbiome stays relatively stable. So you may have transient decline in some of those species, but it goes back to sort of that baseline. In response to your question about bronchoscopy, I am not a huge fan of rampant indiscriminate bronchoscopies. So in general, if I can get an answer through the sputum, then I try to get it through the sputum. But we need to also be clear-eyed about this and say that not all patients will produce adequate sputum samples. It's just, they're the so-called dry bronchiectatics. Those with sort of more mild cylindrical bronchiectasis, they're not going to bring up a sputum sample, in which case there could be a role for bronchoscopy. But in general, I try to get the answer through the sputum.
Well said. And I will discipline myself and stop with the questions with you.
You can keep on asking them, because if you ask 4 questions here, you're going to get 12 different answers.
That's right.
Colin, like most of us clinicians, we're pretty anchored in the culture-dependent methods to assess microbial activity. But I've been struck by the literature showing how stable the microbiome remains over the lifetime of the patient, even during exacerbation. And maybe this is something that both you and Juan could comment on. Is the bacteria a marker of alterations in the mucociliary layer? Is it a marker? And could it be that the antibiotics are doing something other than just eradicating bacteria? Are they altering the homeostasis at that level within the lung, or is the bacteria causing the alterations in the local chemistry, the local environment? I wondered what's your take on that, both of you.
Well, I think that the vicious vortex model would sort of explain it, that this is extremely complex.
Yes.
And I think that if we only talk about bacterial colonization and the microbiome and overgrowth of certain pathogens, then we're missing a huge component of exacerbations, which is sort of the inflammasome. What happens on the inflammatory side? So I think that would be a fantastic topic for another conversation. But in response to your question, O'Neill, no, I think that there's a whole other piece to this that we're only now learning about, that we're only now finally getting to understand.
Sorry, I think this is a good question. So I wonder, for the 16S ribosome RNA sequencing, will it be able to tell you the quantity? I know that it tells you the number of the species. Will it actually show you how many of each species, what's the distribution of it?
The abundance?
Yeah, abundance.
Yeah, so not all, but some of the commercially available ones will have the number of copies.
Okay, that's good. So what I think that, so it's interesting to hear that we do have dry bronchiectasis, because before I dealt with a lot of like cystic fibrosis samples, and then most of the time I think their mucus are really viscous and greenish. So that's usually the sign of Pseudomonas aeruginosa dominancy in it. That's a new perspective in terms of the chemistry and materials property of the mucus layer. I haven't actually dig a lot of like literatures about that yet, but what's interesting is that most of the time, although we see a lot of abundancy of the microbiome, but actually it doesn't mean that it's a lot of cell. There will be a lot of cells in it. So in the lungs, what I will say that you see a lot of mucus, but it doesn't mean that there are a lot of cells in it. So I think that might be one of the reason why it stays really stable and across the period of time. And then, but there is a report in terms of the dysbiosis of the patient's microbiome because of the mucus properties.
Yeah, and one wonders, that led on to the other observation that in clinical practice, particularly among physicians who aren't very familiar with this topic. The repeated course of antibiotics are given, but it might be important to point out here that attention needs to be paid to other aspects of the environment in terms of airway clearance, and not just the antibiotics, which are clearly important. If one looks at the Spanish guidelines, the British guidelines, as well as the European Respiratory Society guidelines, antibiotic therapy, its duration, well, that's somewhat questionable. But whether one needs to have entire 14 days, but clearly, attention needs to be paid to other aspects of the airway beyond the microbial results.
And the duration, O'Neill, of 14 days was really a recommendation based on Pseudomonas. And Pseudomonas, of course, is we encounter it, very commonly in the bronchiectasis clinic. But to your point, I think that as we understand more and more about the inflammatory side of things, sort of the inflammatory pathways, the question is, are we going to need a prescribed number of days of antibiotic treatment, particularly as new targeted anti-inflammatory therapies come to the market, hopefully.
Yes. The more recent article in the I think European Respiratory Journal looked at bacterial load-guided antibiotic therapy and showed that antibiotic therapy at 8 days was relatively okay. There were some secondary endpoints which didn't quite work out, but it seems that 14 days might not be written in stone, but of course we're not disseminating that for everyone. We're simply
and I think that
14 days is a recommendation.
Yes, and I think that it's very difficult to come up with a one-size-fits-all recommendation for any kind of therapy, but particularly for antibiotics, because this is such a heterogeneous condition. To Juan's point, there are those patients who have very, very mild bronchiectasis, but who are significantly symptomatic and still isolate, pathogens, whether it be Stenotrophomonas, Pseudomonas, etc. And they may need a different duration of antibiotics than somebody with cystic, bronchiectasis.
Wonderful. Thank you. Well, that leads very nicely into Dr. Losier's presentation on airway clearance. So we wait on you.
Okay, so I think you guys can see my screen now. So I'm Ashley Lozier. I'm going to talk today a little bit about updates in airway clearance in the non-cystic fibrosis bronchiectasis patients. I have no disclosures. And just to quickly highlight, I'm going to go through a very brief review of pathophysiology of bronchiectasis and then really get down into some of the airway clearance techniques and their mechanisms of actions, their potential sequences, and then discuss the impacts of airway clearance on patient-related outcomes. So as I mentioned, this is just a brief review, as no bronchiectasis talk can be complete without looking at the vicious cycle or vicious vortex, as Dr. Swenson had already alluded to. Really is like looking at bronchiectasis, it really is this complex interplay between inflammation, infection, and airway distortion, ultimately all leading to this inability to clear mucus secretions. And when we wonder about where the role of airway clearance is in disrupting inflammation, really is like we're trying to help with the mucociliary clearance to augment mucus expectoration. Some of the other indications for airway clearance initiation are looking at those who have copious mucus secretions or increased viscosity and cannot clear their secretions, be it from impairment of their mucociliary escalator, or as if they might have impaired cough, reflex, or an ineffective cough. And ultimately, this can all perpetuate into the vicious vortex cycle over time. So just briefly, my learning objectives today are highlighting a brief pathophysiology of bronchiectasis, and then highlighting the airway clearance techniques and reviewing a little bit on their mechanisms of actions and potential sequences that they can be followed in. And then ultimately we'll discuss the impacts of airway clearance on patient-related outcomes. With regards to bronchiectasis, the pathophysiology is really this complex interplay between inflammation, infection, and airway structural changes or distortion. There's two commonly referred to schematics, including Cole's vicious cycle and Flume's vicious vortex, that really highlight this complex interplay. So one of our big questions is always, where does the role of airway clearance come into play? And it's ultimately in helping disrupt the inflammation and helping augment the mucociliary clearance to ultimately break this cycle of repetitive inflammation and airways infection. Some of the other indications for airway clearance initiation may include those who have increased viscosity or copious mucus secretions to help with the clearance. Also in those who have an impaired mucociliary escalator, and in those who might have impaired cough or ineffective cough, where the increased mucus plug-in can contribute to the ongoing infection and inflammation. So what is the mucociliary escalator, you might ask? Well, ultimately, it is where we have an impairment in the cilia and mucus building up on top of it so that you are really not able to effectively clear the microbes in the bacteria, the microbes up to the conducting airways. Particularly in healthy lungs, you are able to move the watery mucus up towards the mucociliary escalator up to the conducting airways and expectorate the mucus quickly. But when you have impairments in the healthy lungs, from, say, cystic fibrosis or primary ciliary dyskinesia, you might have dehydrated, thick, viscous mucus that really becomes quite slow in its ability to transmit up towards the conducting airways. Or in the case of primary ciliary dyskinesia, you may not have motile cilia at all, so that you cannot effectively clear the mucus in that setting. In chest physical therapy or airway clearance, there are several different areas that we focus on, and this can be in mucus problems, exercise intolerance, or respiratory muscle weakness. And when we look at the mucus problems, a lot of the techniques that we're focusing in on are breathing techniques, positioning, and the devices that we will briefly review as well. When it comes to exercise intolerance, we're looking at the deconditioning that one individual might have and giving them additional rehabilitation exercises or encouraging them with aerobic and strength training. And then finally, in those who might have respiratory muscle weakness, we might be looking at doing some inspiratory muscle training with their rehabilitation, or if needed, considering cough assist as another modality of therapies. So one of the big areas that I wanted to focus on today are independent breathing techniques for airway clearance therapies. And to highlight first off on this list is an expiration with an open glottis in a lateral position as one of the mainstays of treatment. And looking at this diagram here on the right, we have just a picture of a normal glottis, is like where it's in an open position at this point in time. And one of the things that I always try to kind of counsel patients on is that in this expiration, it's a slow expiration with an open glottis, or almost as if you were fogging up a bathroom mirror, if you were trying to think of how you were breathing or exhaling out. Some of the other factors that we're going to look at are going to include autogenic drainage, active cycle breathing, huff coughing, and inspiratory hold maneuvers. So when we look at active breathing cycles, there's three components that really make this up, and that really includes breathing control, which is often what you think of as relaxed tidal breathing. It really does help kind of prepare the lungs and help prevent bronchospasm from occurring. And then this is often coupled with huff cough maneuvers that we frequently will counsel our patients on. And this is essentially a change in thoracic pressure that helps kind of push the mucus out towards the conducting airways so that you can effectively clear it. And the principle of that is really like looking at this equal pressure point to try to help in moving the mucus out towards the conducting airways and ultimately out through the mouth or being swallowed at that point. And these two coupled together, the breathing control and the huff cough, are ultimately what we think about as forced expiration techniques. Then the third component of active breathing cycle looks at thoracic expansion exercises. And as you are increasing the volume in the lungs, as you help improve the collateral ventilation, and ultimately this does help loosen some of the secretions as you're increasing the collateral ventilation and the volume. This can be coupled with an inspiratory hold, and oftentimes this is just as like at maximum inspiration, a held breath for about 3 seconds to help as like in augmenting the active breathing cycle. And really, this can be done in many different formats. This is just a common schematic of one of the cycles that you could use in counseling your patient through a component of active breathing cycles. And as like this can be done as like over a series of about 3 to 5 breaths, as like to try to help get to a huff cough and help with mucus expectoration. The next part that I wanted to highlight in independent breathing techniques is autogenic drainage technique. And what this really is a 3-phase breathing regimen using high expiratory flow rates at varying lung volumes to help facilitate some of the mucus clearance. So you really start this at low lung volumes, and you move this up through medium and high lung volumes to get you more velocity to help with the shearing forces and mucus clearance. So if you think about it, the low part, you're essentially working on unsticking the mucus, and this is generally in some of the peripheral lung fields. And then at the medium lung volumes, you're looking at collecting the mucus as you start getting up towards your conducting airways at the latter point of evacuation, and then a huff cough. As we move past some of the independent breathing techniques, we start looking at some of the other techniques that don't require devices per se. And a lot of that focuses on things like postural drainage and the classic chest physical therapy, which includes things like cupping. Nowadays, there's more manual devices such as there's cupping devices along with some of these manual percussors, or you can have an individual who's able to help you with some of this chest physical therapy. But within the postural drainage, essentially you can focus at different areas of the lungs and try to put the body into different positions to allow for spontaneous drainage, and then as like some huff cough to help with expectoration following some of these maneuvers. But some of the precautions to take, specifically in some of these head-down maneuvers, is that it may aggravate things like dyspnea. It may be challenging in patients who have had recent surgeries, specifically if it's abdominal surgeries or thoracic surgeries, where it might be contraindicated. And then in patients who have things like gastroesophageal reflux, this could aggravate some of those symptoms, along with those who might have some increased risk for cerebral edema, where you would not want to have their head down. Then we look at a lot of the airway clearance devices. There are many, so I'm not really going to get into each of these devices, but I just thought this was a nice diagram to suggest what are out there as potential available agents. But if we kind of classify the particular airway clearance devices, we have positive expiratory pressure devices that can be with or without oscillation. Then we have high frequency oscillating devices and intrapulmonary percussive ventilation. Particularly in the intrapulmonary percussive ventilation, this is a schematic of one of the available devices, and then the classic high-frequency oscillating devices are things like the vest, which is a wearable device that patients can wear to try to help with some of this external oscillation to help with loosening secretions. Specifically for the mechanism of action of PEP devices with oscillation, a lot of what we're trying to do is augment the pressure so that the resistance from the pressure helps open the airways. And then ultimately with these oscillations or pulses, it helps to thin or loosen the mucus to make it a little bit easier to expectorate. And I thought this was a nice diagram to kind of suggest how PEP can really help improve some of the lung ventilation. The top graph is patients who are sputum producers prior to use of PEP, and then on the bottom it's after the use of PEP. And as you can see here, there's increasing blue distribution on the ventilation scan to suggest that with the use of PEP, you actually can help with some of the ventilation throughout the lungs. And then just a quick review of a personalized medicine approach to airway clearance, because there really is no one-size-fits-all to airway clearance, which I'm sure we'll get to in some of our discussion. This is a busy graph, and I just want to really kind of highlight the fact that a lot of what comes down to airway clearance approach is really what the patient preference is, along with what their underlying adherence and underlying disorders are. If it's somebody who has respiratory muscle weakness, you might be looking at doing some more therapies to try to help with some of their forced expiration and cough assists and things like that, versus those who have difficulty expectorating mucus with PEP device alone, where you might have to start looking at increasing towards high frequency chest oscillatory devices. One of the questions I commonly receive is, what is the correct sequence of airway clearance therapies? There's many different ways that we can approach this, and a lot of it kind of depends on the degree of patient symptoms as to how we escalate their airway clearance modalities. But you can think of it as starting at a simple level where this might include some of the independent breathing techniques or aerobic exercise, and then escalating this to more complex therapies where you start adding in more of the nebulized treatments, the more invasive or the more intensive devices, along with formal pulmonary rehabilitation. And as Dr. Gu had kind of mentioned earlier, a lot of the questions that we often have is, how well can we get the nebulizers or those fine particulate aerosols down into the actual alveoli, or down into the different areas of the lungs. And for this reason, we often focus on a sequence looking at using bronchodilators first in the appropriate patient population if they have some degree of reactive airways, and then looking more at the mucolytic adjuncts as well, things like hypertonic saline, and then focusing in on some of the chest physical therapy, the PEP devices, along with the chest wall oscillation. And then once we get down to the point of completing some of the airway clearance modalities, we look at a medication delivery. So if it's something like inhaled antibiotics that you want to be delivered as distal as you can, or if you have somebody who has some underlying asthma where you need to look at delivering their inhalers, that's typically towards the latter part of the sequence of therapies. And just to summarize some of the nebulized therapies that are out there, this is by no means a comprehensive review, but a summary. This would just be looking at things like the hypertonic saline. Typically, this is in a 3% or a 7% modality that can help decrease bacterial load and sputum volumes by helping thin some of the mucus. N-acetylcysteine doesn't have a robust amount of data out there, but it is something that sometimes patients will inquire about to help with thinning some of their mucus. As I already mentioned, albuterol in the use of reactive airways disease or on the initial step of the airway clearance. Mannitol really is not available in the United States. And then things like DNase is particularly only recommended in patients with cystic fibrosis. And then nebulized antibiotics is really on a case-by-case basis, dependent on specific infections. So as we get towards the end here, I just want to highlight some of the positive outcomes of airway clearance. So looking at how it can decrease sputum volume and the frequency of exacerbations, and then ultimately can help improve some of the quality of life and cough scoring metrics, along with some lung function. I think one of the main questions that we often get is that, why should I bother with airway clearance? It's a really time-consuming modality for a lot of patients, and for that factor, adherence can be quite poor, as we highlight some of the data here from the European Bronchiectasis Registry, where of the 16,000 participants, only 52% actually reported regular use of airway clearance management. But as I mentioned, it really does have improvements in their bronchiectasis severity index, their decreased quality of life scores, and from the metrics that I've already mentioned, with the outcomes of decreased bronchiectasis exacerbations, and decreased sputum volume, it is ultimately recommended in the main international guidelines right now for bronchiectasis, including the European Respiratory Society, the Australian Thoracic Society, and the British Thoracic Society. So I just want to highlight here a couple of resources that are available for people in clinical practice to look up for airway clearance resources, including the Bronchiectasis Toolbox, chest, along with the Impact B websites that might provide some useful information for clinicians. And just to summarize, that we did review that there are many different modalities for airway clearance to approach the complex physiology within bronchiectasis. And ultimately, the sequence and the devices used are really dependent on what your patient's symptoms are and what their underlying etiology is. And thank you all.
Thank you, Ashley. That was great. Very, very comprehensive. And I think you hit the nail on the head that it's a complex set of decisions and counseling that you do with patients. But I did want to ask you, so maybe get specifics on sort of how you approach this. I think everybody on this call, there's sort of this phrasing and this adage in the bronchiectasis and the CF world that the best form of airway clearance is the one that the patient is actually going to do. And I'm wondering what that means for you. And I was wondering maybe you could just walk us and the audience through like what's your approach to you get a new patient referred perhaps from a community physician, in your case, perhaps from a community pulmonologist who wants you to manage patients' new diagnosis of bronchiectasis, mild to moderate disease, chronic cough, plus minus sputum production, but they have never done any airway clearance, no breathing treatments. How do you approach those patients and what do you sort of commit them to up front? And do you have a goal for them to have certain therapies and interventions on board going forward? I'll open that up to you and everybody else too.
Yeah, so I'm curious to see what everybody else's responses are on this, but I think to your point, that yes, the best form of airway clearance is the form that a patient actually does, and a lot of that really depends on kind of what my patients are willing to do or is like how their symptoms are managed. I typically will start with a simple protocol first, and that might include potentially is a PEP device at the beginning versus active cycle breathing if the patient feels confident in some of those maneuvers. And then I start adding in some of the nebulized therapies. And if I need to start escalating beyond that, then I'll look at adding in things like the high frequency chest wall oscillation or things like the IPV or Volara devices might be some of the more advanced techniques that we'll look at, but by no means are anything common.
And so would you say it's kind of like in the asthma world, it's like a step up therapy? That's kind of how you approach it, small to sort of big?
I think typically, yes. But I definitely have a fair amount of patients who, if they feel that they can do their active breathing cycles very effectively, that along with some PEP and then being able to expectorate mucus following their hypertonic saline may be enough, but it ultimately just depends from how the patient's able to do when they're using their independent breathing techniques. And I harp a lot on those really just because I feel that that's often one of the areas that we are not as effective at doing, and we often are reaching for devices. But unless we're able to effectively clear the mucus as they can actually do some of these active breathing techniques, we really can't get ahead of ourselves with just some of the oscillation that's available out there.
And I take more of a standardized approach with the bronchiectasis patients. But again, as Ashley so eloquently put it, I think I think there's not really one size fits all for a lot of these patients. I try to standardize it as much as possible. In my patients who do have radiographic evidence of retained secretions, they do get nebulized agents. It would be a hypertonic sodium chloride, typically 7%. And it would be an OPEP device, typically the Aerobica. And I try to streamline it and make it as simple as possible. So 10 minutes twice a day, if they're able to, try to fit it into their lifestyle, realizing, of course, that, as Ashley mentioned, some patients just will not be able to adhere to that schedule.
Yeah, one finds that there are some patients who are highly motivated and who are well educated about their disease who tend to prefer the active cycle of breathing and the huff cough as a mode of airway clearance. And I find that more and more. I do tend to prefer the PEP devices that can be attached in line to the nebulizer so that they can shorten that time, right? They can get the PEP and the nebulization done at once. And patients are delighted when they find that. But again, oftentimes patients, they go to pulmonary rehab right after the initial consult, and the respiratory therapists are excellent at taking them through the various techniques, and patients, they tend to sort out in their head which one seems to fit into their schedule, and then they educate me a lot on what works best for them. And I've been surprised. I'll tell you, some of the techniques that I thought would be suitable to a particular patient, the patient tells me, "No, doc, I'm not expectorating with that. Something else works," and that's been an interesting ride. That. Well, thank you everyone for being here. This was an interesting discussion. Very exciting. Thank you.
Thanks
Thank
for having
you.
me.
So nice talking to everybody.